a good informative session together. You can see my title is talking around evidence-based practice, clinical decision-making within the context of advanced nursing practice.
Está em inglês, não está em português, não.
But in fact, I will be mainly speaking from an evidence-based perspective. And I'm not going to give a science or a traditional academic lecture style talk. This is about sharing experience rather than me sharing key references or, you know, new and emerging theories and models. I actually want this to be a practical, pragmatic talk for you. And that's a reflection of myself and my role as the Program Director for Evidence Implementation in JBI. I do want to offer my sincere thanks to the Logistics Committee, the organisers, staff and faculty that have made this conference possible. I also believe that I have some friends who are there and who will be speaking later in the conference as well. So a warm welcome to you all, but especially it's a delight to be with you if you're on the other end of the video and listening in. Thanks for being here. It is a delight to be with you, and I hope I do a really good job for you today. My overall goal is really not to transfer knowledge so much as it is to promote discussion about cohesive, planned approaches to implementation of evidence and what it could be like for yourself as an individual or in collaboration with others to form cognate groups, working together, maybe even forming a network across Brazil for the development of local clinical networks that use evidence-based approaches to clinical decision-making and doing so in such a way that improves the quality and safety of care by having common understandings around evidence-based healthcare, the nature of clinical decision-making and how it works. So before we move formally into the talk though, I should let you know my declarations and conflicts of interest. As you can see, I'm employed by the University of Adelaide, but I have worked in JBI for roughly the last 20 years as the Program Director for Evidence Implementation. I serve on a number of editorial boards as well. So I have no direct or indirect conflicts of interest, and there are no financial incentives attached to this presentation either. Where we're going in this time slot that I've been allocated is we want to look at 3 types of evidence that inform clinical decision-making. That clinical decision-making is really a thinking, analytic process, and it doesn't necessarily imply moving to practice. So we want to look at it as an evidence-based construct and then look at transitioning from knowledge to action, not in the theoretical sense or in the sense of models that provide explanatory context. We want to look at it practically from a clinical perspective. And then if time permits, we want to maybe talk about and talk through a clinical example that might inspire some of you to pick up advanced practice roles and further develop your evidence-based clinical decision-making skills. So really where we're going today, in summary, is to talk about 3 types of evidence that inform clinical decision-making, 3 considerations related to acting on clinical decision-making, and a nurse-led, wild, extravagant proposal for the whole of Brazil to have a good impact. But I think before that, I need to tell you just a little bit about JBI as an organization. So JBI is a independent research organization within the Faculty of Health and Medical Sciences at University of Adelaide. We have been a part of the university since 2010, but we actually began our operations in a hospital in 1996, which seems like a very long time ago now. Adelaide is a very pretty city, and if you ever get the opportunity to travel here, then please do and come and see us at JBI as well. We're a multidisciplinary group. So myself professionally, I'm a nurse, but we also have people across most of the health professions and health sciences working here in Adelaide. You're going to hear me talk about our vision or our mission at several points in this talk. Our vision is a world in which the best available evidence is used to inform clinical decision-making at the point of care, because we want to improve health outcomes globally. JBI is highly collaborative because this is not the kind of mission and vision that one can complete by themselves. And as you can see, our mission involves synthesis, which is systematic reviews and other types of syntheses, transfer, which is, for example, this kind of lecture, which is sharing knowledge and promoting discussion. And it's also to facilitate implementation of the best available evidence related to feasibility, appropriateness, meaningfulness, and effectiveness. And these are types of evidence that we'll talk about in a minute, but it's as they relate to health policy and to health practice. So a little bit more about that in a moment. JBI, our headquarters is in Adelaide. We have about 25 staff here in Adelaide, so we're slightly small, but globally, there is a lot of power in collaboration. And so you can see from this map that we have collaborating centers in many places. There is one in Chile as well as one in Brazil, but clearly, you know, we would love to see much more collaboration in South America than is currently evident on this map. But when you have a big vision and a big mission, the strength is not in what you do in Adelaide, it's in the cumulative and the combined work to produce high quality systematic reviews, to develop and deliver high quality education and training, and to enable, facilitate, and mentor implementation globally. So all the implementation work that's been happening in Brazil has been shared right around the world, and that's how collaboration has an impact globally. The thing that guides all of this, even more perhaps than our vision and mission, is our model. Evidence is at the heart of our model. And as you can see, we talk about evidence-based healthcare relating to different kinds of evidence, and there's different ways of categorizing them. And I promise that I will define these for you in a little more detail later. Just to touch though on the most common problem with definitions around evidence-based healthcare, and that is generally they talk about evidence of effectiveness, and they rely heavily on randomized controlled trials and other quantitative study designs, which is very, very helpful if you're studying pharmacotherapeutics or an intervention. But nurses in particular deal with very complex clinical care needs, and we often need more than evidence of effectiveness. We often need much more diverse evidence that helps us understand people and their experiences, that help us to understand and investigate culture, and to understand ethics within healthcare, for example. And effectiveness is a little piece of that puzzle, but it doesn't provide a full and comprehensive framework for us. But the core message here is there is a model of evidence-based healthcare that JBI uses to guide our work and our thinking, and evidence is at the heart of that model. So our model begins with global health, Evidence-based healthcare needs to address issues of health and well-being that are relevant and important to communities globally. And as you can see, if we go clockwise around this model, global health needs should guide research, primary research. So empirical investigation, we call that evidence generation. So it's the creation of new knowledge through research, through expertise, and through discourse. And that forms the basis of what we call evidence synthesis, which in JBI is primarily through systematic reviews, but also other approaches to summarizing evidence, such as rapid reviews, scoping reviews, qualitative reviews, but also guidelines and guidance for clinical practice. And those are all forms of evidence synthesis. The value of evidence synthesis is that you can take a large body of primary research, evaluate it for quality, pull out the best quality, summarize it in a succinct, accessible way, and come up with a more comprehensive and reliable answer to clinical questions than if we relied on single studies alone. So evidence synthesis is an important program in JBI, and our transfer program actually depends very heavily on evidence synthesis to inform it. So transfer is about dissemination. Ideally, dissemination is obviously an active process, such as this one here. Passive dissemination, of course, is characterized by publishing on passive platforms and hoping people will read it. Active dissemination is reaching out and getting involved with end users of knowledge. So evidence transfer is about integrating knowledge into electronic medical records and running education and training programs, sometimes face-to-face, this year mostly online, of course. But in doing so, to teach people about the evidence that has been synthesized, but also to teach people about implementation, because it would be an unreasonable expectation to think people should implement if they haven't been taught the skills, the techniques, and given access to resources to help them with that. So the JBI model, we have evidence is created in response to global health needs through evidence generation. It's collated, the results are appraised and synthesized, then transferred to service delivery settings where health professionals can use it to implement it and to evaluate its impact on health outcomes, on health systems, and on professional practice as well. The JBI model is the framework on which specific methods can be attached for different kinds of activity. And I've just given some examples as we've talked through the different phases of the model here this morning. So the first component of this talk today, with that little bit of context around JBI, is to think about clinical decision-making. So clinical decision-making infers that we have types of knowledge that we can use, and that it is a process.
Pedro, pode deixar o professor falar. É só minuto, é que a sua voz não está saindo.
So if we think about clinical decision-making as a process, then a process obviously has components.
Só está saindo a voz do professor Clay, do professor Lockwood. Não está saindo a sua voz.
We need to remember that the JBI vision is to see best evidence used to inform clinical decision-making. Then we can study clinical decision-making and understand what the components of it are. Such as rapid review. So clinical decision-making then is based on types of knowledge that all are co-contributory. No doubt you're aware that knowledge can be codified in numerous different ways. We can think of knowledge that informs decision-making as being personal practice knowledge, theoretical knowledge, procedural knowledge. It might be local ward cultural knowledge. It can be reflexive. It could be categorized as implicit or explicit or even intrinsic knowledge. And each of these has its uses when studying nursing knowledge. But for this talk today, we want to consider knowledge within an evidence-based healthcare context. And we're going to talk about knowledge that is codified into 3 dominant types. And I don't think these will surprise you very much, but see what you think. So the first one to talk about is clinical judgment and expertise. This is about applied clinical knowledge or judgment. It is often called expertise. And expertise as an advanced practitioner is the cumulative sum of knowledge and experience used in the context of clinical decision-making. It guides us through day-to-day routines. So that might be to quickly and efficiently set up a hemodialysis machine. It might be to prepare a tray for urinary catheter insertion. Whatever the technical task is, cumulative knowledge and expertise helps with those tasks. But it also includes things that are harder to define. So we might think about being able to identify the exact moment to make the call that a patient will need resuscitation or life support. There's a kind of knowledge that is involved in identifying when a patient needs urgent medical attention. And it comes from that combination of expertise and clinical judgment. It might be expressed as knowing just the right words to use when you're in a conversation with an anxious patient or an anxious family. You don't know in advance what you'll say, but at the right time, you have the right words. And this comes from the culmination of your clinical judgment and expertise. So the second type of knowledge that we can codify in evidence-based healthcare is patient knowledge, often expressed as patient preferences or beliefs and perspectives. This is a really critical type of knowledge. Many patients do develop their own knowledge and treatment preferences over time. And if we as clinicians don't understand their patients' preferences, we can make decisions that have a negative effect on treatment adherence and treatment effectiveness. Just to use a simple example as per on screen. If a patient has asthma, for example, and they use an inhaler to manage their symptoms, if it works well for the patient, if it's easy to use, then they are more likely to adhere to their prescribed medication routine. But if we don't think about the patient's preferences, then we may actually not know the right evidence that supports the patient adhering to their medication routine. So for a patient, maybe the design of the inhaler is important. Is it easy to hold, easy to manipulate, and easy to use? Do they have a preference for a dry powder inhaler or a pressurized metered dose inhaler? And do they have a preference for medication that's required once a day, or are they comfortable with multiple times a day? And to assist with their technique, do they prefer to use a spacer or not? And how easy or difficult is it to keep an inhaler clean, ready for use? So this is knowledge that a patient has that I don't have unless I talk to a patient and understand what's going on for them. Is this particularly important? Yes or no? Well, there is some research, and the answer, of course, is yes, it is important. So if we don't know patient preferences, we might make decisions that cause a decrease in their adherence to their medication prescriptions. And so you can see here, non-adherence leads to worse asthma control. And if patients have an expressed preference for once daily medication over twice daily medication, that also affects their adherence to medication regimes. Because patients who prefer once daily medication will have negative beliefs and find medication intrusive if they are offered an intervention that requires them to take medication more than once a day. The PubMed reference is there if you want to look that study up at any time. I can tell you it's not a good quality study in particular, but it's just for illustration purposes. It shows that patient preferences are important in clinical decision-making. There are factors that can influence adherence and treatment efficacy, which I can't get from my own clinical knowledge. So clinical knowledge and judgment was the first type of knowledge. Patient preferences is the second type of knowledge. And I guess the third type of knowledge is one that won't surprise you at all then, because in a sense, the whole talk is a little bit about this. And the third kind of knowledge is evidence in clinical decision-making. Just simply to describe evidence is empirical knowledge or research. It's quite different to clinical knowledge and expertise, and it's a little harder to get access to in clinical settings because research evidence comes from sources that are difficult to get access to at the point of care. So it can be more challenging when you're in a clinical context to get access to research evidence, but that research evidence is requisite, it is required for evidence-based clinical decision-making. And you can see the summary point here. Clinical decision-making includes expert clinical knowledge. It also includes knowledge as patients expressed preferences, views, or beliefs. And it also includes, in an advanced practice scope, being able to access, understand, evaluate, and implement evidence. So this has been expressed visually and you're probably a little bit familiar with this. If we want to combine these key types of knowledge, then it would look a little bit like this. The evidence is in the middle. That's different types of evidence are central to the process. But we also have knowledge related to the needs and preferences of patients and clients. We have knowledge that comes from research evidence, the best available evidence. And we have professional knowledge, which is often defined as expertise, skills, and judgment. So if we have these three things, we have three ingredients for clinical decision-making within an evidence-based healthcare framework. But you're probably wondering, what do we mean by feasible, appropriate, meaningful, and effective? So I'll just take a minute to quickly go through that as well. Feasibility is types of evidence that investigate physical, cultural, and financially practical aspects of healthcare. Appropriateness investigates cultural and ethical contexts. So you could imagine appropriateness tends to fit qualitative work such as ethnographic, phenomenologic, and grounded theory type studies. Feasibility can be effective, can be positivist. It can be economic, but it can also be qualitative. Meaningfulness is about understanding the personal experience, the opinions, values, thoughts, and beliefs of patients. So that sits very much in a qualitative frame of reference. And effectiveness is research that investigates the relationship between an intervention and a clinical or healthcare outcome. So healthcare professionals and nurses in particular have to investigate a wide range of activities and interventions. And we describe these through FAME, which models 4 core components of clinical decision-making. So really, this helps bring to a close the very first part of my presentation. We've looked at 3 types of knowledge associated with clinical decision-making. We've looked at the purpose of practice is to move from knowledge to action. And I now want to begin to focus on moving to implementation through clinical decision-making as well. So one way to think about that is to think about activating knowledge in clinical settings and workplaces. So in this section, we want to look at activating knowledge as part of a cycle of clinical decision-making. We know knowledge is necessary for action in clinical decision-making, but knowledge is not the same as action, and nor is knowledge a guarantee of action. Creating change requires clinical leadership that includes the capacity to address organizational and local cultural factors that influence practice change, and a recognition that change will be more or less effective depending on the process that I use to try and make a change. For example, if I just tell people what the right thing to do is, this often is not very effective as a strategy. It assumes that I have the knowledge that other people need to listen to, and that if I tell them the correct way to do things, that they will immediately change a behavior or an attitude or an approach to care. And if that were true, we probably wouldn't need to have this talk this morning. But in fact, creating change in practice takes a lot of energy and enthusiasm because it's not quite that straightforward. And that's what we're going to look at next. If I attempt to implement change from a clinical decision-making process, but I don't think about the context in which it occurs or how the nursing staff around me might respond to the change, then I'm more likely to fail than succeed. And if we had time, I have lots of stories from my clinical practice, which are good examples of failure. Simpler to say, change requires maybe 3 key ingredients. That is, we need some awareness and consideration of human behavioral characteristics. We certainly need to understand leadership within nursing. And we need to think about change processes that are accessible, low cost, and sustainable. All of this is important because introducing a new technology, for example, it's not actually about the technology. It's about how it's perceived. It's about whether clinicians feel that it adds value to their workday, that it might save time or improve the quality of care. And it's also about how patients feel about and understand and relate to this new technology as well, for example. And I want to illustrate this for you just with some work that one of my PhD students has been progressing for the last couple of years. So one of my PhD students has been studying the use of robotic enhanced rehabilitation in severe stroke injury, and done several studies. One was looking at the cost and cost effectiveness of robotic rehabilitation. The economic study found that for people, older adults who had had a significant stroke and had significant disability because of that stroke, robotics actually were very beneficial for recovery of function. So robotic devices are good and helpful from his analysis because they enable high intensity, high repetition training. And a clinician can't do that. A clinician will fatigue and need a rest, but a robot does not need a rest. But robotics comes with a significant capital outlay, and it may require significant organizational changes, such as transport and infrastructure development. So robotics could change how practice is organized and delivered. A number of organizations implemented robotics on the basis of the available evidence, but it made no impact on practice. So part 2 of my PhD student's work was to do a qualitative study and try to find out why robotics wasn't being effective, even though the data, the cost modeling and the effectiveness data said that it should be. And qualitative data is the meaningfulness component in the middle of the JBI model. So what he found was, if robotics was implemented with a lack of consultation and engagement with clinicians and patients, then people did not trust or rely or consider robotics useful. The qualitative work also found sometimes robotics was introduced without adequate consultation with staff. So staff capacity wasn't there. Training hadn't been conducted. No one had worked out the logistics of how do you transfer a patient at 8 a.m. in the morning from a ward to a rehabilitation unit, which is located outside the hospital because you need a lot of space for robotics. And rehabilitation specialists themselves who are working in this field felt they lost value as a clinician because robots were doing the work that they felt they should be doing. So it's interesting to have good evidence, but we need comprehensive evidence in order to really understand how to activate clinical decision-making. But what we know from this PhD work is that good intentions and good assumptions don't lead to evidence-based practice. And that when we do implementation planning, we have to avoid making assumptions about who the key stakeholders are and the kinds of knowledge that we need to give them to help move to an evidence-based clinical decision-making model. And you might wonder, is that really important that we move to an evidence-based clinical decision-making model? And the answer, of course, is yes, it is important. Here's some data for you. Not a lot has changed, even though these references are slightly old. We know 30 to 40% of patients do not get treatment of proven effectiveness. And up to 25% of patients will get care that is either irrelevant or potentially at risk of causing them physical harm, because we don't have enough evidence. Yet evidence-based healthcare is a fundamental challenge for all systems in terms of optimizing care processes, patient outcomes, and associated costs. We often don't think about nursing as having a significant cost for the care we provide. We normally think about nursing salaries as being a cost. But if you think about nursing practice, a lot of what we do as nurses, it might be low cost, but it's high frequency or high volume. In other words, there is a high cumulative cost because we do something frequently or often. And some of the things that we do as nurses are low frequency, but high cost. So we actually do have a significant role to undertake in terms of clinical leadership for evidence-based clinical decision-making as nurses. We've looked at the 3 types of knowledge, which is the clinical judgment and expertise, the patient preference, and the empirical evidence or the research evidence. And we've seen from a robotics example that getting that wrong can lead to failures of clinical care. And we can also see even from this data on this slide here that there are ongoing challenges getting things right in clinical care. So what I want to do now is to start to move to look at kind of how do we get there? What are 3 core domains that help contribute to the transition from decision-making to action within an evidence-based framework? I'm going to suggest that there are 3 areas that are worth a close look. The first is human behavior. The second is clinical leadership. And the third is change processes that are accessible, low cost, and sustainable. So we're going to take a few minutes now to look at each of those. And I'm very hopeful that we'll finish on time at the end of this talk for you. But what do we mean by human behavior, and why is that important in evidence-based practice, particularly as it relates to clinical decision-making leading to change? So human behavior or human behavioral determinants is the first of our 3 key characteristics. And it's because when we talk about implementation, it's not the technology that matters. With the robotics example that we just talked about, it wasn't the decision to use robotics that was the reason for success or failure. It was the fact that the administration didn't talk to the clinicians doing the rehab and didn't have a good understanding of what their motivators were. So if you're into the theory of knowing and doing, then the theoretical domains framework on which this is based will be familiar to you. Sorry, I missed that. Could you say and the domains that are listed here are recognized determinants of human behavior. So the combination of having knowledge, skills, having a social or professional role and identity that has been recognized, having clarity in our beliefs about our own capabilities, optimism. All of these are human characteristics or human traits that can have an impact on the way clinicians behave or whether or not they are likely to change a behavior. This has been studied in relation to whether our colleagues in the medical profession will wash their hands or not. So the reference down the bottom there is Kane 2012 from Implementation Science. And what you can see in the bold, so knowledge, skills, beliefs, etc., those bolded attributes are the ones that had the most influence on the uptake of hand hygiene. So these are human behavioral factors that helped to influence the way physicians would or would not choose to wash their hands. And these human behavioral considerations, if we think about them in clinical decision-making, they can be used to guide the development of a comprehensive intervention for practice change. And we can base implementation interventions on these behavior change determinants. We can link these then to effective behavior change techniques. And we can even facilitate, if we're researchers, for example, the development of theory-informed implementation interventions. So there's a lot of really good positive spin-off work that can be done if we consider the human behavior determinants as it relates to a practice change process coming from evidence-informed decision-making. The second important area to think about, of course, is clinical leadership. It's the second key characteristic, really because top-down practice change has a much lower success rate than change that is collaborative with genuine clinical leadership. Effective leadership is a key ingredient in evidence-based healthcare, and it's fundamental for the utilization of evidence. I think we'll just move on. I want to show you how it comes together. So this slide is a visual illustration of the power of clinical leadership. What does it mean and what does it look like? In nursing, we tend to say someone's a clinical leader if they have a high level of clinical competence. And I want to challenge that notion. In fact, to almost reject that notion. True clinical leadership is when somebody understands the organizational vision, understands what are the expectations of trying to meet that vision, and understands the methods or the way that improvement will happen in order to achieve that vision as well. This way of thinking about nursing leadership is very innovative, and it requires nursing to invest in developing clinical leaders that have the practical skills related to evidence-based healthcare, but that also have a bigger world view, a bigger picture of how an evidence-based approach fits within their organization. Advanced practice nurses are obviously a group that are well suited to this particular role. Advanced practice by its nature includes relevant expertise, critical thinking, complex decision-making, autonomous practice, and a focus on effective, high quality, and safe modes of clinical decision-making and care delivery. An advanced practice nurse will work within a generalist or specialist context, and they are responsible and accountable for managing people, often patients who have complex healthcare requirements. So advanced practice roles are really leadership centric and leadership orientated because they're nuanced to local priorities, needs, and organizational requirements. And the training to become an advanced practice nurse has given them capacity to implement methods that align well with organizational vision, as well as professional standards and expectations. You might be wondering, what is the burden of knowledge need related to clinical decision-making from an evidence-based perspective? And that brings me to the third domain that I wanted to talk about in this part of the talk, which is around change processes that are accessible, low cost, and sustainable. It's probably self-evident that we need in nursing change processes that are accessible to clinicians, that are low cost to the organisation, and that result in sustainable change. But many of us don't actually think about what it is we do and how often we use evidence. So this is from a survey. You can see they sampled 3,000 nurses. They had a very average response rate of 37%. But there were some useful key findings that came out of this piece of work. That is that nurses need evidence to inform clinical decision-making on average 1 to 3 times a week. But the same survey also found nurses rarely have the time available to go and find evidence when they actually need it. That we as nurses often suffer from either a lack of confidence or a lack of skills in where to search, how to search, that we don't necessarily have access to the tools and knowledge to help us find evidence, and that we lack know-how as in the critical reading and transferring of research findings to practice. So how do you know a study is a good quality study or not? And what would give you confidence in using the findings of a study and sharing them, for example, during handover or an award round, compared to a study where you would not be confident in the findings? So these are the sorts of challenges that a survey illustrated. And it does show that we do need and would benefit from processes that are readily accessible, aligned with the culture of nursing, that are low cost and sustainable. So the rest of my talk is really pitched at unpacking what that could look like. So I've got about 10 slides to go, and hopefully we finish on time for you as well tonight. Sorry, this morning. So the main one I want to talk about is evidence-based audit and feedback. It is highly effective as a method for moving from clinical decision-making to action-taking, and it has a very good fit with an evidence-based healthcare model approach to practice. You may have been involved in previous clinical audits or organizational audits. They can focus on small-scale, rapid change. Audits often measure organizational indicators, but in the JBI approach to evidence-based audit, we use evidence-based quality indicators from critically appraised evidence to give us robust comparisons with current clinical practice. Using audit can facilitate the development of clinical leadership, and the majority of nurses globally are familiar with the Donabedian model for quality improvement, which is about methods of observation whereby we evaluate current care in terms of its structures, processes, as well as outcome indicators. So the good news is there's plenty of empirical support for audit as an approach to practice change, or the transfer of knowledge into practice. And many nurses are already familiar with audit and its capacity to support practice change. So it fits well, I just said, in relation to models of evidence-based healthcare. You can see this is the implementation piece of the JBI evidence-based healthcare model. And in terms of implementation, we talk about context analysis, facilitation, and evaluation. And in fact, this entire talk is predicated on the JBI model. So using the model, tying implementation to specific methods, such as we have a fellowship program that includes intensive residencies and results in an implementation project. We have the clinical application of quality improvement approaches to evidence-based healthcare implementation. And we use audit and feedback as our approach to achieving that. And of course, this is a mechanism to engage, to sustain, and to build internal facilitation of evidence-based practice change. I want to take a few minutes now to illustrate how that might work in some published examples. So, evidence implementation from a JBI model perspective is about skills, resources, and developing the capacity to facilitate and mentor so that we can bring the three types of knowledge together that we talked about at the start. Those were, of course, clinician expertise and clinical judgment, the patient's preferences or expressed views and beliefs, and research evidence or empirical knowledge, right? So three types of knowledge come together for nurse-led practice improvement. But to move from knowledge to action, we have to draw on behavior change theory to understand what kind of interventions will work best with the people that we want to be part of our change process. We need to strengthen clinical leadership by working appropriately and to utilize change processes such as clinical audit because they are low cost and sustainable for clinicians. I also wanted to say that getting involved in implementation is both clinically and academically rewarding as an experience. It's clinically rewarding because you get to contribute to improvements in the quality of care in the place where you work. That's got a lot of value for yourself as a practicing professional, but it's also academically rewarding because you can also be then involved in publication and further research. So how does this look from JBI's point of view? We run an international implementation program. It is an evidence-based approach to best practice. It focuses on advanced education and training in practical approaches to identifying and using clinical evidence in healthcare. And there's some description on screen, which you're welcome to come back to at another time. But I want to move on and just illustrate a couple of examples of how this has worked in the past. So this was a clinical audit and feedback project using evidence-based quality indicators to improve the care of adults undergoing alcohol withdrawal in a high acuity med-surg unit. The student was one of mine, and here you can see baseline data is that funny goldy brown color. And after she finished her project, she did follow-up data, and that's the sort of blue-green color. Baseline data obviously showed good compliance quite generally across the board, but you don't know until you measure, which is why it's good to have processes that are accessible and low cost. But there were some good improvements, particularly on one criteria, which went from 53 to 100%. The other interesting thing about this work, in terms of it being clinically rewarding, is not the graph and not the results, but the experience that you go through when you become involved in evidence-based healthcare. So imagine yourself working on a ward or in a unit, and then look at this flow chart, because here's what actually happened. And this was from a clinician who undertook this project. She negotiated with organizational leadership to get buy-in on the idea for the project. They agreed, so she had top-down support. She then had to identify the key stakeholders to involve with her in the project, understand and plan for the local context, really consider the human behavioral factors when planning for implementation, and set up her project as a pilot project, and then undertake and deliver a series of comprehensive educational interventions responding to particular needs identified from baseline data collection. So from an implementation perspective, this nurse went from clinician to advanced practice, and she became the bridge between organizational and professional priorities, which is quite a remarkable thing. I didn't know about this when I was doing my own clinical practice, and I wish I did. She produced good outcomes that aligned with the organizational priorities, and was able to develop these in a sustainable way because they aligned with the systems for process and policy development that already existed within the organization. And in doing this, she really demonstrated true clinical leadership, which might be defined as the conjuncture of practical and theoretical knowledge to improve practice and patient outcomes in particular. So she had a very positive experience, and a lot was learnt from that as well, including some of these key outcomes, such as when you start with implementation, think about treating it as a pilot project, small scale, rapid change. And don't undervalue the role of clinical education led by practitioners rather than expert educators. Because you can create an interesting group dynamic in your own ward or unit, especially when it does align with key organizational priorities or policy, and of course links back to nursing practice. So this ties in very well with how we in JBI conceptualize thinking about clinical decision-making and its transition to evidence-based healthcare. It is to enable, when we do this training, it's to enable people to explore strategies that do promote implementation and to collaboratively develop understandings related to clinical leadership and change management, including human behavior change in relation to healthcare practice. So I'm probably going to go just a little bit over time, if you forgive me. If you want to go fast, go alone. But if you want to go far, go together. JBI is a global collaboration, but our mission and our vision is big. We can't do it by ourselves. So we want to collaborate, and we're hoping that maybe you'll feel inspired to collaborate with us as a radical proposal following this talk. And I'd certainly be happy to hear from anybody who wants to. Our approach is about advancing knowledge. It's about building capacity. It's about informed clinical decision-making. And it's about impacts on health and health systems. We partner locally and we act globally, which has quite a lot of benefits in terms of the individual and the organization. So I want to just finish by saying thank you for your time today. I hope it's been a good lecture that has met some of your needs. If you want to read more about partnering and collaborating with JBI, the web link at the bottom of this page is something that you're welcome to follow up, or you're welcome to contact me at any time. Thank you.
Professor Lockwood, can you hear me?
Yes.
Oh, thank you so much for your conference.
You're welcome.
It was such a pleasure to hear you. We hope next time we can have you here with us and hear you.
I would love to be there in person. I hope I gave a good talk within the time frame that you wanted.
Bom, thank you so much. Damos por encerrada a conferência de abertura do 27º Pesquisando Enfermagem. A quem está acompanhando ao vivo, o vídeo com a tradução para o português será publicado em breve. Contamos com a ativa participação de todas e todos no decorrer do 27º Pesquisando Enfermagem, da 23ª Jornada Nacional de História da Enfermagem e ao 20º Encontro Nacional de Fundamentos do Cuidado de Enfermagem. Bom evento!